So my name is Igor. You know, I will be moderator of this roundtable, and Dr. Larry Tupler will be also a moderator of this roundtable. We will discuss what we started discuss at our roundtable and some new questions. So first we would like to discuss risk factors. Risk factors may be protective factors of related to risk of Alzheimer's disease and related dementia. Let's start from a pool questions. We have audience watching our event from Zoom, and also partly we have a reasonable part of individuals watching us from lobby of our event. So I would ask people from lobby to log in to Zoom in order to have an opportunity to vote for our meetings. Only who are in Zoom can respond to our questions. So, and Masoud can submit the first question, and you who see on Zoom and people in Zoom can vote, and then we will see our results. Here are the results. Yeah. Yes. This the question is factors that determine the risk of Alzheimer's disease and dementia. We see. You see. Yeah. We have equal.
Igor, we can't see.
Huh?
We can't see. It's too small. It's too small.
Okay.
It says panelists can't vote, so a lot of people in the group can't vote.
Did you send us a link or what are we doing?
How do we vote?
We can't vote in the room.
So do you count? But some. Yeah, we must.
Yeah, it has to be just one.
Just one.
You can log into the Zoom link.
Yeah.
So don't feel for
You can
Okay, good. Raise a hand. So people put us that if you panelists, you count the backward. We will So what we see? We see equal votes for social determinants of health, environment even higher, physiological even more higher, healthcare a little lower, comorbidity higher, and genetic. So all factors from this group are almost equally important to our audience. What do you think? How would you range these factors? So, for example, if you are a public health expert and you have an opportunity to make one intervention, yeah, which factor would you suppress? What do you think?
I'll jump in there. I don't know, they're all really connected, in my mind.
All of them are connected, yeah?
Yeah. So I would try to find, a pathway through all of them that, led to some discussion.
So maybe in this case we have to work with the factor which would be easily to modify.
Or the one that's fundamental to the rest of them.
Okay, and what would be easily to modify from this? So genetics is not possible to modify, yeah?
Again, wishing you modified genetics.
So now, environment. That's mine. Sorry.
In this case, it would be better to perform PCA.
PCA,
Yeah.
like prostate cancer, what do you mean? What is
Principal
component analysis? Principal component analysis. But this is to speak about analysis. But okay, we have, for example, principal component. We have first principal component. We understand that this principal component will be highly significant. And what can we do next?
After that, we need an intervention.
Intervention to first to principal component.
And
But how to perform a specific intervention if you have 30% of environment, 20 from physiological? This is a principal component, right? and how would you design a respective?
an alternative is the bootstrapping method. It means that to take an individual from one place
What I'm speaking about is this just methods of analysis to identify most important risk factors, right? Or a mixture of them.
to identify risk factors of one needed to make an intervention.
I'm not sure that I understand how to make intervention for mixture of these so different risk factors. Yeah? Yes, please.
So I presented on comorbidity for the most part, but as a sociologist, I would say education is the primary social determinant of health that could be modified to improve or reduce disparities in
Yeah, but look-
ADRD.
Education can be effective in 50 years, right? If you modify education now, the effect will be available in 50 years, yeah?
It would take some time.
Well, they're showing that, continuing education improves your brain health. But I think going back to the whole idea of inflammation, that so much of our ADRD risk, what we've heard for the last 2 days with the gut microbiome and the inflammatory processes in the brain. I just feel like looking at the root causes of those things is what's really important, and that would be social determinants of health. Right? Is that the root cause?
So, and you also suggest to think about intervention in the area of social determinants of health, yeah?
Yeah.
So, Masoud, can you run number 4, our pool? Our pool, this is questions from social determinant of health. Which one is most important? Please suggest.
I already showed my cards.
Do you see now?
Now.
Panelists should be now able to vote. In case they can, please let me know. I'll try to fix it.
We can.
You can, right? Okay, good. Thank you.
Again, we have similar results, yeah? Access to care, physical activities, education. Not so much people believe that social isolation is important, right?
Well,
To me, physical activity goes with behavior, right?
Physical activities could be part of behavior, but behavior is included just negative habits like smoking, alcohol, maybe inappropriate body mass index. Yeah?
Igor, could I have a comment?
Yes, please.
I think, let me tell you a story first. About 20 or more years ago, autopsy studies show that human brain of people with Alzheimer's disease is full of different kinds of infections. Fungi, bacteria, and viruses. So second for this time, that's environment. They came from the environment. They were not
Broadly environment.
right. So that's a component of environment which is important. And at the same time, people link neuroinflammation with Alzheimer's disease and many other Alzheimer's disease-related dementia. Neuroinflammation could be produced by the presence of these infections in the brain. That's together with many other toxins. But since that time, more and more people analyze this issue. More and more people became convinced that infections are really the cause of Alzheimer's disease. And the culmination of this whole analysis came the paper, which came about 3 months ago from very well-known person from Canadian medical association, Thomas Fulop, who said that the only reason for development of Alzheimer's disease is infections. So if we will be able to prevent infections, penetration of infections to the brain, we will stop development of Alzheimer's disease. So from this point of view, yeah, still.
But look, this is hypothesis point of view or proved evidence.
He formulated it as a problem which he solved for himself. He convinced that this is the solution.
So when you talk about infection, are you talking about bacterial infection? Are you talking about viral infection?
That's what I mentioned. There are 3 types of infectious agents: viruses, bacteria, and fungi.
Prions is another one that the frontotemporal dementia, for
Absolutely.
example.
That's it's not exactly infection prions. It's kind of modification of protein, which produce it looks like infection spread, right? But it's not infection by itself. But I absolutely agree with you that it could be some toxic materials which switch the construction of protein in the prions. That's what could happen, and that's the answer to Thomas Fulop, that maybe there is some other way of thinking about it. It's not necessarily infections, but autopsy shows that infections are there, right?
So if this is 3 types, maybe you can give us percentage of these types in this autopsy's measurements. Do you have an impression?
I wasn't also deeply involved in analyzing this kind of material. I'm convinced that infections, well, more than 50%, let's say, if it would be pooled something.
So infections, you would like to say that infections could be responsible for more than 50% of all Alzheimer's cases?
That's my impression. After reading, of course, my opinion could be biased because I focused on this kind of literature. But many other toxins, of course, could influence, and like prion, I agree completely, which is ignored by these people. But and prion also are found in the brain, so maybe that's a kind of competing cause as well. But it means that not only infections, but also different kinds of toxin which influence protein synthesis would affect the situation. And it's not only Alzheimer's, that's any kind of damage in the brain.
So, but look, infections, this is a separate story. This is quite different from education, for example, from outcome, from other factors. But we know that all these factors are associated in Alzheimer's disease.
But maybe via infection.
So less education.
Better education prevents infection.
Absolutely.
Okay, what about API?
So
And API, maybe it is a question that I would like to ask, whether genetics in general and API in particular will affect Alzheimer's disease or infection. Infection is easily spread in presence of,
For example, characteristics of blood barrier penetration. Yeah.
yes.
yeah.
Sure, Igor. Yes.
So of course, it's multifactorial. And infections obviously is part of it. one factor. As a geriatric psychiatrist, if you look at it, and we know that major depressive disorder, for example, fear, is a predictor. Those, and we saw in this meeting, almost 37%, close to 40% had MDD or other behavioral issues. Now, is the common mechanism toxic? Is it similar to infection? I don't know. Okay, the changes which happens, inflammation, does major depression also caused by infection, or inflammation is a better word, brain getting inflamed and leading to the Alzheimer's pathology.
But look, MDD could be a part of a diagnosis of Alzheimer's.
Very true that most of the time, and most of the studies have shown that depression or behavioral symptoms appear much before the person developed MCI or later Alzheimer's. So maybe you're correct, maybe part of the whole spectrum. Because depression itself, by itself, causes dementing symptoms. What is called dementia of depression. They have cognitive problems, probably not full-blown, and are helped by treating with antidepressants. So with improvement in depression, you might see some improvement in cognition that may be temporary. Okay, and over a course of the illness, you might see further worsening of cognitive problems.
Okay, here, can I weigh in on this topic? I'm not allowed to vote, but let me just say something. Okay, so the predominant view is that education is the #1 factor. I completely agree with that for reasons of Occam's razor, which is you can address everything that comes below by enhancing education, right? You can educate about the dangers of smoking and drinking and all of that. Education's the pathway to income in this country. Social isolation, that was the problem in the pandemic, right? That the kids couldn't socialize, right? So education, particularly recess, which is my favorite subject, right? You get together and you socialize. Access to care, you can educate people about access to the medical system, and finally, physical activity, again, recess, gym, class. So I would argue that education would be the most effective way of addressing it. I can also say that it's been well documented that education in women has been largely responsible, the lack of education in women has been responsible for less cognitive reserve. Women have really caught up in terms of education. So now there are more women in college than men. So I don't know if our next speaker, Dr. Thorpe, is going to address disparities in men. But I think in 50 years, we're going to see a reversal, and there'll be disparities maybe in men because there are fewer in college and they're getting less education. So that would be my argument.
So this is to the question of how to measure the effect of education, because there are studies comparing women now and women in past, rate of Alzheimer, and they see a quick decline because of improvement in education.
That's right.
And this is not observed in men. The same story, because probably during this period education was similar. And this study suggested that maybe education is the most important.
So, Larry, can I just ask you a question? One of the very interesting studies which was presented yesterday, where it was a VA study, they looked at the years of education and they looked at some kind of testing. You questioned that too, which measured IQ. And they showed that it was more important than the years of education. Now, to be honest, I don't know what that test is. I don't know what domains that test is really looking into. And again, in a very specialized VA population, becomes a question about.
It
So
wasn't-
what's your
The outcome was wages, was labor, was wages, was not, had nothing to do with dementia. He just used that paper to present his method. It had nothing to do with dementia.
So it was related to what? Wages?
Wages to labor.
So
There was a labor economics.
wages are related to income.
Oh, absolutely.
Wages, they are related to education.
Absolutely.
We all know that.
Absolutely.
I mean, to answer your question, I believe it was on the AMNARD, it was a test of reading of irregular words, which demonstrates how much you've read, how many, your vocabulary, your ability to recognize things that don't conform to the rules of, syllable phonemes and that kind of thing. So really, the quality of education is far more important than the number of years, right? So that's what we really want to measure is how much do they know? How much did they retain from their education?
That's why it's more about literacy.
Exactly.
Let me comment about genetics, because there was concern that whether or not we can change genetics. So everybody knows that E4 allele is the strongest risk factor for Alzheimer's disease, right? However, even two carriers of the two copies of the E4 allele may not develop Alzheimer's disease, right? So this natural experiment, people who didn't carry two copies of the E4 allele and didn't develop Alzheimer's disease, they have something what modifies or buffers adverse effect of the E4 allele. We need just to find this. That's it.
Or maybe it is just probabilistic question.
No, because this population risk for careers of the two copies of the Alzheimer's disease, two copies of the E4 allele is about 40 or 45%. So less than 50% develop Alzheimer's disease.
Causally established factor.
But that's maybe because they died from other reasons before.
Maybe, but still they did develop. So
Yes.
something prevented them. They are more robust than the others.
Are arguments that having a bad allele does not mean that you will develop Alzheimer's with probability 1/4, say.
Yeah, this is to the list Julia demonstrated us. If you don't have, you can't develop. If you have, you must develop.
This causal relationship, but we are talking about just chances.
Many people without APOE4 develop.
Yeah, 50% of people develop Alzheimer's disease with APOE and 50 without.
Yeah, but in this case, this is something probabilistic.
No, I mean that, in terms of, there is no causality, right?
Okay. So look, we have, we discussed, now what we discuss is the risk factors for Alzheimer's disease risk. But what about risk factors for disparities, for difference between two risks? Are they the same or not? Let's ask pool number 3. Oh wait, pool number 2. Pool number 2, sorry, about the risk factors for disparities.
Yeah, distinguish.
Yeah, the factors
And apathy.
Very interesting. So
genetics, defined by
the dementia is very distinct.
Environmental factors. People believe that the social determinants of health and environment factors are most responsible for disparities, for difference. Yeah,
And environmental factors alter DNA.
so why is, you mean,
Right. So is this genetics in the context of what you're born with or what you measure with in
look, of course,
by the time of the study?
how currently we measure genetics, just some blood sample and measuring.
Oh, I see.
What we have. So, this is actually what we discussed at our workshop, these factors, and this is an agreement to what we have. Social determinants of health, maybe just social, economic status, environmental factors, and comorbidity. Genetics also important as people started to believe. So I discussed methods yesterday, and it was under some assumptions with using the proportional hazard Cox model. Yeah, generally structure of predictors of risk should be similar to structure of predictors of difference in the risk. So factors that are important for risk are also important for disparities. That's what I received by manipulating with this model. So does somebody have a specific opinion that maybe there is some other factors responsible for disparities, not responsible for rate? So is it possible?
It might be that gene-environment interaction is, so it's not just one particular component on this list, but interaction between components. Like genetics produce phenotypes only with interactions with environmental conditions and with internal genetic, say, milieu as well. So it's not just separate issue. So it's really might be important to put this stuff together, and also information, knowledge about this gene-environment interaction, I mean, education again. So I agree with you completely that education is on the top of this. As more we know about why this disease is developing, the better we could make protection, and the better people who are educated, if their salaries allow them to make such kind of protection, they will do this. They will find better place of living. They will buy expensive drugs. They could and they understand what are the protective factors. So again, this is all related to each other, and that's.
Look, and do you mean that gene-environment interaction should be more important for disparities rather than for risk?
No, for both.
For both?
For both, yes.
This is what we receive. If something important for risk, it's also important for disparity.
Yes, yes.
Mm-hmm.
So, Igor, make a comment?
Yes, please.
Yeah, I just want to remind you, I think it was last year's keynote speaker, Jakob Stern, or was it 2 years ago? Anyway, a very important component of his presentation was that Alzheimer's disease, when it's manifest, is heterogeneous. Yeah, it's heterogeneous. You have typical progression. You have rapid progression. You have people who start on the day of diagnosis with psychiatric symptoms, delusions. You've got behavioral problems, you've got verbal outbursts. You have very, very different presentations across a whole array of measures, multiple domains. Is it possible that the extreme heterogeneity manifests across all of these people who are given the same label, Alzheimer's disease, that heterogeneity may be due to many of the causes, different balance. The thing that causes people to show up with behavioral disturbances, psychiatric symptoms may have a different balance of causes than the people who show up with rapid progression. And they may be different than the more typical progression, the 6-year survival type of people. So I've sat and trying to understand all the different causes that have been outlined over 2 days. And it just struck me that all of them could be important, but depending on the balance, the manifestation of the disease could be different.
Would you like to say that averaging may be not a good idea, but instead we should study heterogeneity and the effect of different, maybe small groups and the progression of each of them, and maybe then we should average. Yeah.
The average American, and if you pardon my statement, but the average American has one test. So if you think about that, it doesn't help you understand what happens to any average individual in the US. Averaging can be a big source of distortion of understanding. Anyway, that was just my comment.
So I'm just recalling Nick's presentation yesterday about the differences between Mexican Americans and Mexicans in Mexico, and how Mexican Americans, if I recall correctly, have a greater propensity for development. Is that what?
So my work has been on multimorbidity, and specifically Mexican Americans born in the United States have higher multimorbidity burden than Mexican Americans that are immigrants. I think that's kind of the core of that.
Me and my friend, my buddy from Mexico, I like to go to Mexico and serve. He indicated it's probably something like lifestyle, food, and these types of issues. But I don't know. It was just a question for you, Nick. What do you think?
I think related to that, I've talked with a few people about it. I think there's culture. I think that's probably the biggest predictor of those differences is culture in terms of social support, familialism, those kinds of things. But also that effect could be a selection mechanism, right? Healthier people are able to immigrate. So that's when we're doing population estimates of that. That's what we see. And that's kind of what I'm working on, is trying to flesh that out a little bit. But certainly I think for those groups, if I had to make a bet, it would be social support. That's higher among Mexican immigrants and I guess you would say non-US based. Well, I wouldn't say all cultures, but specifically Mexican.
So if you identify a comorbidity, responsible for risk of disparity, this is only a part of answer. We need to understand.
It's very multifaceted, like all of these questions that we're addressing. And I think we go back to maybe our home base to think of what drives, like what's the primary driver of these differences. And for me, I do think it's social determinants of health, as the upstream determinant of a lot of these things that we're talking, genetics that we're born with, not necessarily, but even our thinking about intergenerationally, our parents' genetics are influenced by environment. So I'm very much a social determinist.
Also, please check if maybe somebody from our audience would like to say us something. Maybe they raised hands or wrote a comment for us.
There are no questions in the Q&A.
Okay, good. So we still have one more pool. So this is to the question how to analyze and which type of data are more appropriate for this analysis. Let's try to understand this. We have many data mentioned today, mentioned by you, for example, the different type of data. So
You want to pick more than one?
yes, please speak most important from you for conclusion. So people believe that specific studies, cohort studies, first of all, like Framingham, for example, yeah. Maybe ARIC and CAS is very appropriate, and also this data probably should be linked to environmental and maybe survey data and genetics. That's what follows from this picture. We didn't add linked data set to this because everybody would prefer linked data set, I think. So, but we have to keep in mind that many of data sets are linked to each other, and this is improves opportunity of this data for analysis. So, would somebody like to comment this?
Could I, Igor?
Yes.
I think we should not ignore that it's so today that in addition to all this data which are linked here, and there are many other data which are collected from Alzheimer's disease and also aging-related, other aging-related health disorders. You can use any kind of omics data. Omics is not here. It's not here. And it's expensive data collection, but people go there. Why do you think they go there? They look at epigenetics, 28 or 30 million CPG islands. They look at metabolomics, they look at proteomics, they look at gene expression data. So, and they spend huge amount of money to find something. What do you think they try to find? And let's continue. Okay. Eric mentioned that heterogeneity is very important. Why? Alzheimer's disease is a multifactorial trait, right? It's an interplay of genetic and non-genetic factors which produce it. People are talking about precision medicine. What does it mean? Individual medication for any person. In order to do that, you should really understand how disease is developed in any person. This is understanding this hidden heterogeneity. The way to understand this hidden heterogeneity is look at more and more data and develop a tool. It is a challenge for all of us. There is no tool yet to combine all this omics data with survey data, with Medicare data, and with all data available for one person to estimate what this person really is in terms of all the data which he or she generated. When we will understand this, we will learn a lot how to deal with disparity, how to deal with all kinds of problems related to this person. So it's really challenging, not only in data collection because it's very expensive, but it's also challenging for people who develop methodology. And I think it's a Nobel Prize. If people will learn how to do that using modern computers are now in good shape, it will be quantum computers. But how to put all this stuff together, not like right now, it's huge amount of data, people look at a small subset of data, develop some model, produce results and publish the paper. huge amount of data used yet. Okay? People,
And you would like to say that if you use another small set of data for the same individual, yeah,
that's,
they will produce another result.
developed, like Eric knows how to put the data together using BOM model, right? Let's develop further this idea of Latin class model.
Linear latent structure
like-
analysis,
yeah. So this is the way to address the problem and resolve the issue, to find the way of data integration, not specific data, like genetics itself will not resolve the issue. Let's put everything together and think how to develop the tool. And I think we have a potential for this.
So you would like to say that latent structure methods like BOM, like other latent methods, would be a good candidate for such.
That's right. That's right. And stochastic process model is a good candidate.
Yeah,
but of course it should be
model
modified
can deal with limited number of variables.
at this shape, in this particular form, right? The more complicated form is it, the question of identifiability issue when you increase the dimension. It should be some compromise. The ability to deal with more data requires some reasonable, let's say, changes in the models to adjust and put everything together.
So if we have more data for individual, yeah, new type of data, we have to better predict this individual's risks and outcomes, right?
Yes, that's the idea. And okay, people are talking about machine learning, artificial intelligence. These are like ad hoc tools without any particular mathematical proof about convergence, but people use it. And they produce results. Nobody knows, well, what is extent, what is the error in this. But it's still people have hope that it will work. So it needs just more careful justification. It needs more testing. But again, that's the way to use all possible information.
But look, machine learning and artificial intelligence, this is a little different story because for this method, we need many thousands of individuals and not so much variables or features like so in our case, we have limited number of individuals and huge information per individual.
That's Eric's methods and ideas.
So is it just latent class, latent methods, BOM methods? Please.
I'm wondering why you don't have international data.
International? Yeah, but international also could be of this type.
Yeah. Right, but international data can give us more combinations. And like education may be different in different countries, and maybe you'll be able to better understand.
Or maybe not necessary to have different education, just compare different countries. Yeah, but there are different kind of biases there.
Well,
First of all,
there are lots of
measurements
biases everywhere.
of diseases.
Lots of biases everywhere, and I agree there, it increases heterogeneity. But sometimes increasing heterogeneity is actually good because you could find subsets that are more similar in some ways and heterogeneous in ways that you can't measure if you're restricted to locality.
Higher region of risk factor, no?
Hi, can you hear me?
Yes.
Hi, everyone. Yeah, I just wanted to make a comment if that's okay. I really like this question, but sometimes I feel like there's a loss of focus around what a health disparity actually is. And so, it's my understanding that health disparity is due to like social and economic or environmental causes. Oh, wait, I just lost the video. Okay. And so I think a lot of the discussion I've been hearing has been focused on like proteomics, for example, and then, talking about international data now. And I think I just kind of want to refocus what we are actually defining as a health disparity in this conversation, because I feel like we're getting stuck on methods now. rather than I'm interpreting this question as what is the data that can help us identify? And I think that actually broadening the scope and not focusing on within community, considering a health disparity again is, something about social and environmental or economic causes, we can kind of get lost in like trying to find that answer. Does that make sense?
Nice job, Casey.
Oh, thank you.
Can you come in?
Oh, sure. Well, I mean, she's right. I mean, the definition of health inequity is something that's mutable. It's changeable. It's not genetics. If you look at the classic definitions of health equity, so it's I think by default focused on other types of exposures. Speaking to what Casey was talking about, and as well as environmental and other types of exposures, but there are these kinds of exposures that are not genetic.
So, and you would like to say that we can have classic measurements like difference and rate between two groups. Yeah, but we can first, before we explain this, we can separate on intentional individual preferences, something like this, and we can separate all observed disparities, and maybe only a different part of them can be explained using different ideas and different factors.
I think so. I'm not sure if I followed the first part of it.
Yeah, because look, it could be structural racism, for example. This is a part. But it could be just individual preferences.
Oh, I see what you're saying. Right, but I think that's a tricky way of framing it because, for instance, when people talk about lifestyle factors, that I think is problematic language because lifestyle factors makes it sound like it's somebody's personal individual preference if they're going to go for a walk, if they're going to exercise, if they're going to work, eat well. But it's really structured. But there's so much about those health. I like to think of those as health behaviors because they're really profoundly mediated or impacted by those structural and systemic issues. If you live in a food desert, if it's not safe to walk outside, all of those other things. So I think we have to be very mindful when we think about health inequities, how we, the lens we take into it, because it's not necessarily just individual preferences, because that almost makes it sound like it's Latinx folks' fault that they have 1.5 times more dementia, and we certainly don't want to frame it that way.
Okay, because just what we measure.
Sorry, I may interject about so basically oftentimes topic that is raised is like walkable cities or not. So that if we're living in a very urban environment where you can walk to places, that's one thing. And if you cannot go anywhere without a vehicle, then you're getting less exercising just from going about your day. So I just wanted to point out as that could be considered as a lifestyle choice if I have to take the car to a spot where I don't have a choice because it's so far away. I have to take the car.
Right, but even that, like everything's like more nuanced because even if you live in a walkable city, if you're a Black man, you might not feel as comfortable walking depending on where you are, or a Latinx man because of your own physical safety. So I think we really have to think in nuanced ways about all of these issues.
And some of that may not be reflected in, in terms of exposures, right? So
Right.
You said,
Yeah.
like these behaviors that have been conditioned, like you're like a woman, you have like different choices. I think you would make, like you wouldn't be like, oh, I parked in this, creepy looking parking deck and no big deal. And if for a guy, I was like, I don't think anything of it. But if I'm a woman, it's like, I'm not there, I'm not parking at this level.
Yeah.
And so some of these may not be manifested itself in terms of an exposure. But I mean, we're wrestling with it. I think there's a lot of different data sets that, I think there's a difference between like hypothesis generating versus hypothesis testing. And I think we need both. But to your argument, I think, there are some techniques that are out there like machine learning and artificial intelligence that can kind of bring together a large amount of data in terms of breaking across all these different silos, but there's still a lot of interest in terms of whether or not you can believe it. A lot of it sometimes is a black box. And do you have any confidence in the results? Are these results validated? How do you validate it? Some of these mechanisms, and some of this could then goes back into the methodology of it, but then I think also some of these in terms of the questions of how you actually execute some of these studies.
Actually, there is a series of paper from Institute of Medicine, and they suggested a modification of rank and replace methods to partly address what we discussed. They suggested to replace only structural variables, but variables related to individual preference should not be replaced, or something like this. And this way we could allow them to separate this effect and explain only a part of total disparities, something like this.
Interesting. Yeah, but to think about like ways to actually capture that information in these data sets that may not, be readily available. Like you can, you have this AI generate all these different, fancy data.
Or representative.
Yeah, exactly.
I mean, so we're trusting data that was created that doesn't reflect people's lived experiences.
Exactly. Yeah, like you really have to be understanding in terms of like how these data were collected. Who are you collecting it from?
Right.
And so that's why going into your international experience and these other what population are you getting these data and what are you basing these findings on? And so that's why there's a big push in terms of trying to have underrepresented minorities and other populations be represented in these data and not just non-Hispanic whites.
Can I just say something about the word minorities? I try not to use it. As you pointed out, that's not going to be the case. And in some years, I mean, to me, it's a stigmatizing term. I would really like to see us as a science get away from that.
Okay, we have 5 minutes, and I saw hands from Heather, Roberto, and Tom. Let's please
Sure.
say.
I think what I'm saying probably fits nicely with what was just said, that for me, one of the biggest challenges with data is that when data are granular and phenotype people well enough to really try to understand what some of these factors might be that lead to disparities, or to characterize how the disparities are affecting people. One of the real challenges is we often don't want administrative data for that, but then any data it's so often not representative, and it's so often our fault that it's not. And I'm saying the people who collect data, because the very same things that have created disparities that make these choices difficult, such as exercise or diet or things like that, all come into play, obviously, when a person's considering if they're going to participate or be able to participate in our research. And we do very little historically to try to reduce those barriers, or even, make that an equitable playing field for people to be involved and contribute to the evidence database. So for me, that's one of the biggest challenges in trying to study this, is that we sort of have a choice between data that doesn't really capture the issues that are most pressing, or data that's really fraught with bias.
Thank you so much. I really appreciate this forum. Looking at the inadequacy of quantitative itself, don't you think this could be a better approach in creating qualitative study, such that we have mixed method? Because when we talk about the lived experiences of people, expressing that through questionnaire might not really capture the life experience of these people. So what about mixed method complementing a quantitative methodologies?
Great point.
Yeah, I feel like that's an important methodology that, we missed in our 2 days is, people who do mixed methods, or, anthropologists, people who do qualitative work, to really understand the richness of, that's a really good point. I'd like to bring that up.
Yes, we discussed this a lot at the last GSA. Yeah, we have to think in our suggestion for next year conference, one of the sessions should be mixed, more mixed research, like qualitative, quantitative research. Maybe we will be able to discuss this. Thomas, last, please comment.
Well, it's been really exciting. But there's one thing that I also feel that maybe all these discussions that we're having, I haven't been in the field for long enough or been old enough to really pick out some of the aspects. But prior to very few years ago, we dared not talk about these things we are talking about because they were all about, it was very heavily guarded. And even to today, that guarding continues. I remember at a recent conference, someone very highly respected, after there was a presentation about racial differences about amyloid PET aspects. And this individual just got up and asked that, are we really sure that what we are seeing is Alzheimer's disease? Don't we think this could be something different? And what I actually got on, I just got like a brutal like that. And the way I came on that, look, we all say it in a very fancy way. We want to be inclusive, whatever term we use, inclusive, open, whatever we say. But we forget that the key word for this opening up is heterogeneity. To a large extent, we don't want to see the heterogeneity. We want to keep the models we have built heavily guarded, very, very well protected. I want to see that applied to everyone. That is not what it's going to be. And that's how the research that we do needs to open up. It needs to really allow and be less protected in a sense that, yes, you may want to win a Nobel Prize for something you built, but you also have to allow for the actual truth of the science to tell you what is happening at the level of the individuals that really.
Thank you. So, thank you for everybody for participation in our discussion. We are done with this round table, and please